Good afternoon and good evening, everyone. Welcome everyone to the Aspire web series, The Troubleshooters in ART, organized by Aspire Education Committee. Today, I am Dr. Somjet Manipan Virat from Thailand. We will conduct this session on the topic of when IVF fails, what is next? So we know that over the past 40 years, we have progressed a lot in terms of the success in IVF. We have progressed a lot, reduced much of the complications. Anyway, we are still away from achieving 100% success rate, in which it gives us challenges and opportunity to improve what we are doing. So as many of us are clinicians and embryologists, when we face the IVF failures, sometimes we get to a corner how to deal with the patients, because we all know that, if you cannot keep patients into treatment, okay, sometimes patients may lose their chance to achieve pregnancy, because we all know that the success has been directly related to cumulative pregnancies, in which it means that we need to be able to keep patients in the treatment as much as possible. And today we have three distinguished speakers. Okay, so today we have three distinguished speakers. Let me introduce all of them, starting from Professor Abdul Qadir Abdul Karim. Professor Karim, he has his primary medical degree from Trinity College in Dublin in the year 1999. After completing his master in OB/GYN, he has joined University Kebangsaan Malaysia Medical Centers in 2011. And he did subspecialty in training in reproductive medicine in the UKM Advanced Reproductive Center. He also has a PhD in endometriosis, progesterone receptors isoform. He currently is Deputy Head of Obstetric and Gynecology Department and the current President of the Malaysian Society for Fertility Preservation. And he also holds the position in the National Reproductive Medicine Medical Education Subcommittee of the Malaysian Medical Councils, and also a representative in the Ministry of Public Health, Ministry of Health Reproductive Medicine Training Subcommittee for Malaysia. And the second speaker will be Professor Chairun Seng. He is a founder of Taipei Fertility Centers, and he also is an honorary professor at Taipei Medical University. He graduated his MD from Taipei Medical University and has his Master of Public Health in Maternal and Child Health School of Public Health from Harvard University in the United States, before becoming the research fellow in fertility and endocrinology Department of OB/GYN at Brigham and Women's Hospital, Harvard Medical School in Boston. He currently is Secretary General of Aspire. He also is currently the honorary president of Taiwan Endometriosis Societies, and he also is the founder of Taipei Fertility Centers. Okay, and he also has held many distinguished positions. And the third speaker is Professor Robert Lahoud. He was born in Germany before moved to Australia in 1984. He graduated from University of Sydney with Bachelor of Medicine and Surgeries, and he also was under training for IVF in Australia. He was a fellow of the Royal Australian and New Zealand College of OB/GYN and had received subspecialty qualification of Certificate of Reproductive Endocrinology and Infertility in the year 2002. he currently is the clinical director of IVF Australia North Shore and also a visiting medical officer at the Sydney Adventist Hospital and also senior clinical lecturers at the University of Notre Dame. With his role as a director at IVF Australia, he has involved in the management in creating the IVF Australia Lite program to offer patients more affordable IVF treatment under the IVF Australia umbrella. So today, we are honored to have these three speakers with us. Okay, so hello everyone. Hello. Hello. So today, our discussion will be not a formal one. Okay, it's gonna be I will ask the questions and we will all help discuss. And also, I would like to encourage our audience, in which I have heard that right now we have more than 400 audience who are seeing us online. I would encourage everyone to send in the questions in the Q&A box. Okay, and I will read out your questions and then we will discuss on the questions that all the audience has. I try to answer all the questions that we obtain. Okay, so let me get started. We are all IVF specialists. Okay, so we are not about to touch base much on the IVF, how to do it, but let's get to the point that we see patients, we offer them the treatment. Okay, before we get started, we point out what are the problem, and then we go all the way to the treatment. But once we get the negative pregnancy result, okay, so what should we do? Okay, what should we do? First of all, we need to confront, okay, the patients. Okay, there will be so much of the questions coming in. Okay, so let me first go to Professor Lahoud. Okay, when you see patients with the IVF and they are like good prognosis and then they fail, what will be your advice in terms of approach them?
Okay, I think it's obviously important to be empathetic towards the patient at that stage because and just to imagine what it's like when you've put in all the effort and I think having that close relationship from before you even start the cycle is to explain that this might be a bit of a journey that takes time and that it's normal for embryos not to implant. Implantation failure is actually a normal part and it's nature selecting out a good embryo. And if there's some problem that we just don't understand yet, then this is what happens. And this can take a few attempts. So this is a normal thing. That doesn't make it any easier if it doesn't work. So I think it's about then acknowledging the fact it hasn't worked, showing, I guess even saying, look, I'm really sorry that it hasn't worked, but this is normal. What can we learn? And what do we do next? I think, and then it's do we do more tests? And I think it's really important to analyze what the problem is. Is it the problem with the embryo? Is it the problem with implantation? Is there other problem that seems to be there? So I think that really helps for the patient to get some understanding. And I think often they blame themselves a little bit. And so if you can just say, this is normal, this happens to lots of people, it gives them that relief that it wasn't anything they did wrong. It gives them encouragement to keep going because it's a journey and it's our job to motivate them to get to the end line.
So from what I hear, I think we probably had to start to prep patients before we get to the failure. Am I right? So probably we have to get started from setting the correct expectation before the treatment. Okay, because I believe that many of us has faced patients when they get onto the IVF, they expect something like 100% success, just like some other surgeries or whatever. So probably we may have to prep our patients before we get started. Then it could be somewhat easier to deal with the success. Okay, and also to handle the failure. Okay, so next, let me ask Professor Kadir. Well, when you had patients, okay, and then they get unsuccessful treatment. Okay, so I believe that there will be so much questions from patients, whether you have done most comprehensive workup already, or what else should you offer. Okay, and again, that will be somewhere that you sit in the middle between the fact that sometimes patients ask, well, if you advise to do this test, why don't you do it earlier? Okay, so what is your point that you want to discuss or tell the expert about how to deal with it, not to do too much investigations and not too less?
Okay. Thank you very much, Dr. Somjit. I actually concur with Prof. Lahut just now. It's not just that patients sometimes blame themselves. Sometimes patients blame the clinician for not doing enough. So for some of or most patients, because on my setting here in Malaysia, because patients are self-financed, the majority of them, even at our university hospital, most of it is still self-financed. Even the investigations, they have to pay. So on our setting, we do the best, some basics, and we still go by a practical way in terms of we do the basics investigation, and then we still go by the best method based on the patient's profile before we start a treatment. And then once they come with a failed cycle, then we'll go through, because after a failed cycle, you have more information. Some patients are very receptive and they want to understand. Some patients do not. So you go step by step, and for those who wants to really understand, you explain to them in depth. I mean, you'll get these odd patients that after explaining half an hour or 1 hour, they'll go outside and still ask the your nurse at the counter the same questions. So you have to gauge the sort of patients you're dealing with and what sort of expectation. So I will actually go through in depth. And if I gauge the more of the type that is very critical, that I do have some very critical patients asking whether what should we do next, why we didn't do this and why we didn't do that, I will explain to them rationally that not everyone requires everything. Not all investigation is first line. So if they can, if you explain this compassionately and make them understand the irrational things that you're doing, I think they'll be more acceptable and continue treatment with you.
Yeah. So I think by having the guideline, whether national guideline or international guideline, will help to talk with the patients that you abide to the guideline, and then you are not over investigate, because sometimes over investigation leads to over treatment, and then it leads to excessive financial burden to the patients. Okay, so I think I believe that most of us as clinicians, we always face the problem when we talk or see patients. For those who fail, sometimes they come back and ask you, why don't you do this test, that test, and so on. Okay, and especially when the result come back kind of positive, and they think the other way, rather than thinking that we have provide them with the treatment that is at the most cost effectiveness. They look the other way, that you just forget something. Okay, so let me go to Professor Zheng. Well, let's say you have very easy, good prognosis patients. Okay, they come in for the first time. Okay, they get the embryo transfer, very beautiful embryos. Okay, very beautiful embryos. You probably advise them to go with single embryo transfer with current recommendations on all the guidelines for good prognosis patients, and then they fail. What would you do next in terms of investigation or reassurance?
Thank you, Somjit. I think when patients come in with failed IVF cycles, then I will ask two main issues. One is the embryo is the quality embryo, is a euploid embryo. The other thing is the microenvironment. The endometrium preparation is enough or suboptimal. I think these are two key issues. If the patient's age is young, for example, under 35, I would say maybe 50% of the good quality, good morphology embryo is euploidy. But if the patient is above 35, maybe reaching 40, maybe only 30% or 25% is good quality embryo. So in that case, I will try to do the PGT-A. Okay, if they fail, patient is advanced age, PGT-A may be the optimal test to find out the good quality embryo. The other thing is usually we use the frozen embryo transfer nowadays. So if FET with not thick enough endometrium, then I will try to improve the endometrial thickness. Or if I use artificial cycle, then I will change natural cycle, just change something, because still have some advantage of natural cycle, because they can produce a relaxing and some growth factors from the copsultin rather than. So some fine tune of this technology I will do for the next treatment. Or even I will use a little bit growth hormone in the very beginning, day 2, day 3, short small dose to induce IGF-1. Maybe they can thickening the endometrium a little bit. We have some several successful cases use this methodology, technology.
Right. That is interesting. I totally agree. Thank you. And well, let me go back to Professor Lahoud. When you find patients with failure, how you categorize them? You look at all patients who fail as one, or you look at them differently?
Yeah, I think they're very different, and it's really important to have a clear categorization yourself. So obviously the good prognosis patient that's young has a normal embryo. Even in those patients, I often refer back to the Richard Scott paper where they had 3 PGD normal embryos and someone under 35 good prognosis patients before they finally had 95% of people pregnant. So it's normal that the first embryo doesn't take, and you've just got to keep going. And then there's I remember a nice presentation last year from Dagan Wells on why do PGD embryos, which are tested at the highest chance, still not implant, and how there could be genetic problems and the mitochondria might be deficient in energy. So there's so many reasons why embryos don't implant, and it's still the embryo. You often need more than one go, but it's obviously very different in, like if you have a poorer prognosis patient, someone over the age of 40 who's got a low AMH and is probably not going to generate a lot of high quality embryos. And that patient, yeah, it's really important to prepare them beforehand. And clearly the reason is very likely to be the embryo and aneuploidy. And yeah, as Professor Zhang said, if we can do PGD on those, sometimes that would give them at least a reason for why this is happening, but that's difficult. So yeah, absolutely, you need to classify the patient into those big groups sort of thing, and then focus on how you can make the embryo maybe better, or just say, look, we're on the right track, just keep going, let's use the next embryo, and hopefully that will be the one.
Thank you. So, well, as we have mentioned about PGT-A, so let me ask everyone, okay, all 3 of you, about how common you offer the PGT-A. Okay, do you offer the patients with PGT-A since day 1 they get into the treatment, or after how many failures that you're gonna offer them the PGT-A? Can I start with probably Professor Kadia?
For PGT-A, usually I would offer almost all of my patients above 35, whether they would want to do PGT-A. But I still do emphasize that PGT-A can only improve your chances so much, because the embryo factor is the biggest chunk, almost 50-55%. But you still do get, as Professor Lahoud said, you still get normal embryos, and you have to explain to them that there are other factors that we need to address. But that is one thing that we can start off with. We streamline or identify the area of failure. Now we've ruled out the embryo problem is a euploid embryo, so we can focus on other things. So we are streamlined, and we can reduce the time to achieve the pregnancy we know it's already an aneuploid embryo, that would be also another reason. So if you have a discussion with the patient, because it is still self-funded, some of them, if they think economically, they would take that option as well. Yes? But I routinely offer to all my patients above 35.
Okay. Okay. And when we do the PGT-A at the moment, we probably had more and more results coming back as mosaic or segmental mosaic or segmental aneuploidy. How would you deal with it, Professor Kadia?
Okay.
Would you recommend them to not make use of them, or do you advise them to make use of them? And also sometimes, if compare between PGT-A result versus the embryo quality morphology, let's say you have better quality embryos, but they are mosaic versus the lower quality embryos that has euploid. How will you decide which one to go first?
Thank you. So for the results, if we have an option, we have several blastocysts that is of good quality. Usually a pragmatic way to think about it, first selection is the euploids. Second selection, if you have many euploids, you go with the euploid which is have a higher, if you're using AI, IDA, or some scoring, you will use that one. If you don't have any euploid, then comes the discussion about the mosaicism, how high it is, and whether what chromosomes are mosaic. And you need to discuss with the patient, because there are also theories about autocorrections and things like that. So if they are stuck, that's the only cycle they've invested, and they can't go for any more cycles, then you have to make a pragmatic approach and decide that's the only embryo that you have, whether you want to take the risk and do NICC later on if they do get pregnant, and move from there. So I think if you have a systematic systematic way of approaching this, and you explain to them from the beginning before you even start, that's why I emphasize on PGT-A counseling before you even venture into it, and the possible results, then they are more clear. And after getting the results, you have if you get these results, this is what you do. You get these results, this is what you do. So you have a clear idea of that. So some patients like that, some patients prefer not to know.
Thank you. Well, let me ask Professor Jung, what is your position on the PGT-A? When will you offer them when they have a failure?
The number one, the concordance rate of PGT-A, because this from trophectoderm, so the only 80% with concordant with inner cell mass. So that is the potential limitation, right? So the 80% success rate is at the top. And then come out the mosaic pattern, mosaic blastocyst. And in the healthy embryo, it tend to be keep the normal euploid chromosome inside the inner cell mass, and the waste, the abnormal, tend to be expelled to the trophectoderm, which potential to be a placenta tissue. So that is why the mosaic pattern, and the mosaic pattern in our studies, low-level mosaic, about 8%, they can repair by themselves, because although there is a mosaic in the trophectoderm, but inner cell mass is normal, but still the success rate is 80% compared with euploid embryo. As far as the high mosaic, only 50%. And the last one is the segmental mosaic. Segmental mosaic in our studies is even better than low-level mosaic. So if you get a low-level segmental mosaic, you can use as a for transfer if the patient do not have the euploid embryo for frozen embryo transfer. So that's my comment. And I agree with the Abdullah Kadir. The PGT-A in my practice about 30% of my patient, because 50% of my patient age over 40. So in my daily practice, 30% of my patient they use the PGT-A. So that is the very real scenario. But still, you have to look at the ERA because I think about 3 years ago in USA, the Sherry group they claim ER is useless, and they published a paper in JAMA. But when you look at the paper carefully, all the patients are very young, under 35. 2 groups, each arm 350 control and with a PGT group, and found out there's no difference. But in my studies, patient age over 40, I don't think the endometrium is as good as the young patient at about 30. And as you know, the endometrial cell, even the mitochondria into the endometrial epithelial cell will be different from a young patient. So if the patient is older than 40, in my studies in our center, we collect 150, almost 50% of our advanced female age, their window of implantation shift almost 1 day later. So I think in a couple of months ago, I discussed with Carl Simon. He's the inventor of this iGenomics ERA. He also agreed my point. If the patient getting older, maybe the the time of transfer time maybe half day or 1 day shift to day 6 or day 5.5 days. Yeah, but if you can do a ERA, that's much better. So embryo quality important, environment, endometrial preparation, receptivity, thickness also very important.
All right. Thank you so much for bringing up the topic of the ERA, because I believe that we have quite a few debates on the ERA, and the information has been on the webs online. Everyone, when they Google all the patients, I believe that most of us has come to the point that we have to discuss with patients about. Yes, Professor Kadia.
Point about the PGT-A and the lab. I think it's a good idea if before you start sending your embryos for PGT-A, you have a discussion with your lab counterparts. What's their threshold or sensitivity? Because some of the advanced systems can detect mosaic at a very high rate because it's very sensitive. So if you're really into the world of progression of NGS and detecting abnormalities, so as I assume as the technology progress, there will be higher and higher detection. So that's, you have to have a discussion what threshold you want to take as your threshold.
Yep. Yeah, I totally agree, because right now I believe that there are so many more publications coming out on the use of the mosaic embryos. So it almost becoming kind of a standard that we should discuss and talk with the patients on the use of the mosaic embryo, because otherwise you throw away a significant number of embryos in which you most of the study has shown that the implantation of pregnancy success with mosaic embryo, especially with the low degree mosaic, is as high as 50+%. So it means that otherwise you throw away half of this embryo. So I think everyone agree with you on this, but again, if we talk with the patients before we do the PGT-A, it will make you get to the point of discussion with the patients easier, because most of the time patients think that the result will be just black and white, normal versus abnormal. They don't know that there's a big gray zone. So let me go back to the ERA. Let me go ask Professor Lahoud about, well, how often do you do the ERA, and what is your position in terms of those who fail IVF?
Look, I probably do it in a select group of patients, mainly the ones who have, by my definition, recurrent implantation failure. So they're patients who normally have failed frozen embryo transfer cycles. So obviously the ones we struggle with the most are the older patients doing PGD. We can't biopsy the embryos, we're putting them in fresh because at the end of the day, PGD doesn't make an embryo better. It's the same embryo. So we can't actually ever improve the chance of success. We can only select an embryo out. But in those patients who have, good embryos, they've had several frozen embryos, maybe 3 or 4, then I'll do an ERA and adjust the time of the transfer. But I'm not quite convinced about the data that I would use it on everyone. But I'm very interested to hear about the older patient, and that's certainly something I'd like to look out for, sort of thing. But yeah, I think it's something we really need to keep investigating, because it's such a good idea and such a good test, and if we can nail down when you use it, then I think we'll be able to apply that test more widely. But yes, I use it in a select group when I really think they're good prognosis patients. They've had several embryos that should have maybe implanted and they haven't.
Thank you. So, well, what is your positions or your idea on the ERA for Professor Kadir?
I agree with Prof. Lahud. There would be a select patients, but for most of my medicated cycles, to further select, usually during the transfer, I will look at because to me ERA affects, especially when you use medicated cycle, because not everyone would have the same absorption of progesterone. So if the patient, sometimes we do see in the vagina when we're doing transfer, there's still a lot of progesterone micronized still available. Sometimes you question whether the absorption is sufficient, whether their receptors will get stimulated for the proper window of implantation. So to further select, besides implantation failure, I will look for these cases that during the procedure I will see too many leftovers after 4 or 5 hours of inserting progesterone.
In that case, are you more interested in measuring progesterone level or the ERA?
The ERA, but if you do actually get a lot of leftovers, because you can't say that the absorption would be the same for every patients that they will respond to the same medication. So in that sense, I do believe ERA will work, because they are using the same mock regime, and you're testing whether it's actually mature during that time when you're doing the biopsy. So in that sense, it is theoretically to me sound, because the absorption is different. But for natural cycles, I don't usually use ERA, because the natural corpus luteum should respond, and they should respond to their normal endogenous progesterone as well.
All right. So, well, that is very interesting, because, we had one questions from the audience on the absorption of progesterone. Let me read the questions, and then you may answer. The question is there a role for serum progesterone before starting luteal support in an HRT cycle? Whether you're going to do progesterone measurements before you start the progesterone, I mean, for HRT cycle, I assume that it is for FET cycle with the AEP using estradiol and progesterone. Is there a role to measure progesterone before you start the progesterone?
I think people should measure it, because if they ovulate naturally, then obviously the timing will be out. So at least you measure the endometrium and the progesterone, and then we often measure it before the transfer, the day before the transfer, which probably a lot of people are doing now, is to make sure the progesterone, whatever it is, whether it's vaginal progesterone or injectable, that is high enough so that the luteal phase seem to be adequate. So we do that. Whether that's totally proven, I guess, remains to be seen too, but that's something we tend to do. So we do measure it before we start any support, and we measure it the day before the transfer too.
And what level are you looking for before the transfer?
Yeah, so we want it to be over 30, and
right? You're talking about minimum.
We use the non-American version.
Yeah.
Picomoles, so we get and so at that level we're happy to go ahead. If it's too low, we sometimes rescue the cycle by increasing the progesterone, looking at either oral preparations or injectable on top of the pessaries, And then or we cancel the cycle altogether and try the transfer again. And this is for a frozen cycle, and we often do natural cycles in Australia. The HRT cycles have sort of gone a bit out of vogue, but I'm not saying there's a problem with that, but everyone seems to have moved on to natural cycles a lot, which is a lot more work here.
So I totally agree with you. I also use the cutoff around 10 nanogram. I mean, pretty much the same conversion, 10 nanogram per ml before the transfer. So, well, talking about the natural cycle, because, you know, there are more and more publications on the embryo transfer in natural cycles, in which some has shown improved implantations, and many has shown lower pregnancy complication like pregnancy-induced hypertension, C-section, postpartum hemorrhage, and so on. Okay, so when you take natural cycle, frozen embryo transfer with the ERA, okay, because, you know, when we are talking about the ERA, we are talking a window to implant, but when we get to do the implant in natural cycle, in which it is quite difficult to really say when is the R0 of ovulation. Okay, you can roughly say that ovulation is today, but you cannot really pinpoint that it will be 3 in the morning, 3 in the afternoon, the precise time of ovulation. So it means that the time of implantation will kind of vary by 12 hours. Okay, and sometimes maybe up to 24 hours, because you don't really know the precise time of ovulation. So in that sense, okay, does it kind of, you know, go against the belief on the window of implantation that you have to be precise with the ERA? Let me ask Professor Jen.
First, I agree, serum level, progesterone above 10 nanogram is safe level, especially for artificial cycles. But usually when you look at the natural cycle, the serum progesterone level usually about 15, because more progesterone produced from the corpus luteum. So that is why it's better. Also another growth factors produced from the corpus luteum. And you mentioned natural cycle. I would prefer modified natural cycle, because you cannot check the LH surge or progesterone during midnight. Patient come to you in the daytime, but still in the midnight you don't know. So when we use the modified natural cycle to HCG to trigger ovulation, I think it's more appropriate for daily practice, and easy to control the window, exactly 5 days or 6 days, depend on. So I a little bit abandoned the true natural cycle to use, and as you see, even the HCG also can sustain the production of progesterone from the corpus luteum, so it's also good. And also you see much higher than the HRT. I is 10 nanogram, but you know the serum progesterone level is not equivalent to tissue, which is endometrial progesterone level. So that is the limitation, because so this is why I think natural cycle is better. And in terms of, we just said PGT-A, I remember the Luca Giolaromi from Italy. He used to be the president of ESRI. He mentioned the PGT-A is still a fetal surgery, because we remove 3 to 5 cells from the trophectoderm, and we do not know the long-term consequence of this small surgery. So I think we still have very careful when we do PGT-A. And I think the total accumulation pregnancy is no difference, but we can reduce the time to pregnancy. Also, we can, at a certain period of time, select the best embryo. I think that's the advantage. But still, we have to watch out the drawback of this technology.
Yes.
Please, Professor Lahoud.
We do use a modified natural cycle, so I should have been more specific, and I agree that makes it much easier, just to have the trigger and know that booster HCG is there, sort of thing. So I agree very much.
Yeah.
That's the way to go if you're not using HRT.
Yes, Professor Kadir.
I still do use some modified natural cycle, but there are instances just for practical purposes. You do get this large follicle sometimes when you do the tracking, and sometimes you always wonder because you're not using any antagonist. So you do wonder, is there an endogenous surge of LH before you give the trigger so that the timing might differ? So in practically, because I don't have the luxury of doing a blood test and getting the results immediately, I just advise the patient just to use the LH kit or the ovulation kit to see whether it's positive before I trigger with HCG. So if it's positive, I don't abandon the cycle. I actually do scan the following day to see whether it has rupture on the preceding day to adjust the date of the transfer.
Okay, thank you. So, well, let me read out. We had quite a few interesting questions from the audience. So, let me ask the group. One of the question is, I had a question. A patient did 2 times IVF. They got around 13 to 16 eggs each cycles. Both cycle has poor quality embryos, and our embryo does not go well until day 5, so we cannot perform PGT testing. The mothers already did PRP 1 time after first cycle, but results still not good in the second cycle. Should we treat the mothers with PRP again and any other treatment, and treat for the fathers with medicine, since the sperm, it will take 3 to 6 months for recovery and result can be varied? Okay, so let me summarize. I think we are talking about the IVF cycles for people who had a good number of eggs, but the embryo quality are not good. Okay, but they do PRP. I assume that it kind of being injected into the ovaries, but still not obtaining good quality embryos. So what should we do? Let me ask Professor Chen.
I think this patient is probably old. I don't know what the age. If the patient is old, maybe during the control ovarian stimulation, I will add some LH at the very beginning. Yeah, because it seems to be the quality all are very, very poor. But if the problem is due to the sperm, okay, the sperm, if the sperm is poor quality, poor motility, and oligospermia, and then I will maybe advise our embryologist to use the calcium ionophore, try to induce calcium oxidation during the fertilization, maybe some help, yeah, some help. So because I do not know how old is this patient, but it seems to be the egg is enough, 13 to 16 eggs, right? It's good, but the problem is the poor quality or the poor. I don't see the poor fertilization. I don't know whether, yeah. So try to change, fine-tune our control ovarian stimulation protocol and to see. So maybe we'll see different outcome. And the PRP only for those poor responder or advanced age, very low AMH, maybe increase the number. So PRP is not going to increase the egg number. Yeah.
All right. Okay, thank you so much. I totally agree. And is there any other comments from the other two, Professor Rahul, Professor Kadir?
I think one point we should make is also about the health of the patient, the lifestyle. I think that was when someone, I mean, yes, there's sperm, there's eggs, but is there anything in the lifestyle we can change? And in particular, the male, I think often, like where I work, I don't even see the male. The woman presents, and the male might be very obese and quite unhealthy. I mean, they'll tell me if he's smoking and drinking a lot of alcohol. But if there's something that the couple can do from a lifestyle point of view, that can obviously help to maybe improve the quality of the egg and the sperm. And then obviously, as Professor Zhang said too, like we can look at different additives to the stimulation, different protocols, supplements. There's a whole list of things that can be, and obviously important in a younger patient, particularly if the embryos are poor, then you need to really look at all those factors, particularly because there's unexpected poor quality embryos, sort of thing. So yeah.
Yes. I do agree that PRP, I only focus on poor responder of diminished ovarian reserve, but the numbers or the quantity looks okay for 13. But I will be much interested in knowing when the question is poor quality eggs. Do they mean the morphology of the oocytes is poor, or is it too many M1s and GVs, or what do they mean? If it's poor morphology, such as there's a lot of vacuoles or too much is a very rough cytoplasm, sometimes you can actually check whether there's an excessive stimulation, because high estrogen can also has been shown to cause poor morphology, and this can lead to poor fertilization or poor blastulation as well. So I will go and talk to the embryologist. What do they mean? Is it the immature or the morphology in terms of the the cytoplasm and vacuoles formation? If the oocyte quality to me looks okay, they say grade 1 or moderate grades, and the sperm there is still is injected and there's slow progression after day 3, then some hypothesis is more to the male factor, the sperm factor. Then the basic lifestyle and stop smoking for the male is good, but what we can do in the lab is use advanced selection methods. Can use microfluidics, or you have other devices that can select the sperm. So depending on which stage the problem that the embryologist sees, is it the morphology from the beginning, is it the fertilization rate, or the cleavage state they'll see problems, or where is it? I usually like to talk to my embryologist on this.
Thank you so much. So let me go to the next question from the audience. Talking about stage 4 endometriosis with adenomyosis, planning for frozen embryo transfer, besides giving GnRH agonist for 3 months, is there any advantage or disadvantages of continuing giving letrozole for 3 weeks to suppress the estradiol following 3 months of agonist before starting estradiol for endometrial preparations? The question probably is that any benefits from giving letrozole in addition to GnRH agonist for those with endometriosis, adenomyosis? Well, who would like to share? Professor Lahoud?
Actually, look, I probably wouldn't use letrozole. I'm not sure if the evidence is strong enough, and yeah, but I think if the tubes are like, I think the tubal factor is another important factor in severe endometriosis. If the tubes are damaged and they they may have to be removed. If that hasn't been done, that's something I would look at, and then I would probably possibly look at something like a GnRH agonist cycle. But often we just use natural cycles without too much more intervention. It still works. But look, obviously these are special cases, and they may more likely have implantation failure. So I'd really like to see what the panel has to say about that one too. So yeah.
Okay. I'll just like to get the question correct. So meaning the patient has endometriosis, and they have down-regulated the patient, and now they want to do endometrial preparation.
Yeah.
Okay. So for endometriosis, what I usually do and what is theoretical sound, actually to me 2 doses is sufficient, because it takes two weeks before the estrogen level comes back to the normal, and you have hypoestrogenic state after that, and 2 doses is sufficient, and you can start using letrozole, which is some sort like anti-estrogen as well, will be counterproductive, because you already down-regulated. So if you already down-regulated and you want to increase the estrogen further, to me is counterproductive. I will start straight away with exogenous estrogen. what's available at your center. But because I don't think letrozole would work because it's anti-estrogen, because the patient is already hyposuppressed, so you cannot get the negative feedback to the anterior pituitary.
Right. So, well, thank you so much. I think letrozole, someone has talked about the tissue estradiol. Okay, that is why some people has discussed about the use of letrozole on this group of people, especially for adenomyosis. But again, the data is still lacking. We probably may need for more information. So, well, let me ask the panels some very common things. Well, is hysteroscopy before frozen embryo transfer is really effective? Means really need to do. And if we find very small polyps, like 5 millimeters polyp, should we get it removed before frozen embryo transfer?
Okay, can I start?
Yes, please, Professor Kadir.
So, I don't usually do routine hysteroscopy unless I do see something on the transvaginal scan. Okay, but if there is suspicious areas, I would do, and because you can already see it on transvaginal scan, means it's big enough. So I would do and remove whatever pathology that is there, because if you have the larger the polyp is, the less the surface area for the implantation of the embryo, and you're not too sure whether it will affect the milieu of the endometrium as well. So if I do see on transvaginal, then I would do. But in case like most of the patients recurrent implantation failure with top quality blastosis, then I would consider, but not routinely.
All right, thank you so much. Well, we had so many questions from the audience in which probably we had less than 10 minutes. I will try to answer as many as possible. So, well, let me ask the panels about, we talk about ERA, so I'm not going back to that again, but what about the intralipids? Okay, PRP injections in the endometrial PRP and intralipid infusion in those with recurrent implantation failure. Is there any role, or would you recommend the use of intralipid and PRP infusion in the uterine cavity?
Yeah.
Okay, let me ask Professor Chen. Yes, please.
We correct about 100 cases of the PRP for those patients with thin endometrium before transfer. It seems to be they can increase the pregnancy rate, also increase the thickness of the endometrium. So I think the PRP still have some role for endometrial preparation if they are thin. And the other, I just mentioned, we can use the, because usually we oral, right, estrogen. So we can plus oral estrogen plus the gel together, because the absorption route is different. Some from skin, some from the GI tract. So, and not enough, you still can plus a small dose of growth hormone at the very beginning of the menstrual cycle. Small dose, day 2, maybe 8 IU, and day 4. And then this growth hormone, they can produce IGF-1 from the liver, and also they get some receptors in endometrium. So still, the already proved growth hormone, small dose, they can beneficial effect to increase the uterine receptivity as well as uterine thickness. So the gel skin, the gel, the growth hormone or PRP, you can use individualized to patient. I think they can get some beneficial effect to increase thickness.
Yeah. Probably we have time for 2 more questions. The next one, what is the, do you have any opinion on the HCG perfusions in the uterine cavities before embryo transfer in those who had recurrent implantation failure? The HCG perfusions into the uterine cavities.
I don't have the experience.
Yeah, I also
don't know, rather than Abdullah.
Because the HCG intrauterine infusion has not been proven to work. I understand the rationale because you want. I'm not too sure whether it's actually to thicken the endometrium or to help stimulate the environment to become better for the implantation or to stimulate the HCG. So that I think because there's so many theories, that's why it has not been proven to work.
Yeah.
Mm.
Yeah, I think there are some studies, but mostly are kind of, small retrospective studies on the use of the SCG perfusions on the to stimulate the receptivities. But again, I think it is still off-label and not very well proven. Okay, so I'm sorry. Okay, so sorry.
Yeah, on that note as well, you were mentioning regarding intralipid as well, whether to give as an intrauterine infusion or intravenous. Those patients, I suppose, it's not routine use. If you do suspect it's immunological problem and you want to suppress in that aspect, you've tried everything else. I suppose there is an argument to try that if you've tried everything else. But I suppose you just reserve this for specific cases. If you're talking about non-proven and experimental things.
Okay, so I think, let me see, we have 4 more minutes. Okay, so we can have one more questions and then probably we have to wrap up. So let me ask the last questions, okay, about the chronic endometritis. Okay, it has been discussed a lot about the chronic endometritis. First of all, it is quite difficult to make a definite diagnosis because the diagnosis we do not really have the criteria for the diagnosis, and then no protocol for the treatment of the chronic endometritis. Okay, so let me ask the panels about your position in terms of workup on chronic endometritis and for the treatment. Would that help in those with recurrent implantation failure?
I think more recently the subject chronic endometritis has really sort of come up a lot in Australia. So we are probably performing more hysteroscopies or endometrial biopsies at least. And we are treating this with 2 weeks of doxycycline or some sort of antibiotic that's appropriate. And then the question is, do you biopsy afterwards or not? That it depends a little bit on the patient whether they can tolerate another biopsy or not. But I think it's sort of rejuvenated the idea of the hysteroscopy and checking the endometrium. And I agree with you that the diagnostic criteria for obviously you need to have a good pathologist that knows exactly what they're looking for. But I think that's changed a bit too in Australia now. And then obviously you can also do the genomic testing. But I think generally from a histopathological testing, it's something we're seeing more and we're treating more. I'm not sure how much it helps, but certainly anecdotally it does seem to help some patients. Yeah.
All right. So I think we had come at almost 1 hour. We had time for 1 hour, but still, there's quite a few things that if we keep running this program, we can spend like 4 or 5 hours because, I believe that we all have experience in failure as much as the success. Okay. And today, I would like to conclude these sessions on when IVF fail, what is next? Okay, I would say that, from what we have discussed, okay, it seems that we probably talk to the patients to offer about the PGT-A in those who have recurrent implantation failure, okay, with no other explainable cause. We may talk to them about offering the EIA to evaluate the uterine receptivities in order to find the most proper implantation window, okay, and moreover, we have to be kind of more supportive to our patients, okay, psychologically and sometimes financially, because in many settings when treatment is out of pocket, finance and emotion that comes together, okay, so there's we need multidisciplinary approach to this group of people because we want them to achieve the best treatment success means that we need to keep those with good prognosis in the treatment as long as possible. Otherwise, they may lose their chance to get successful treatment.